Yes, on the Monday Report tonight, we are delving into matters prostate cancer. I promised we'd take a couple of questions from our audience. I'll start with you, Dr. Kelly Oluoch. You head this institution, the Kenya Medical Training College, which is hosting us tonight. What do you make of the concerns raised by Dr. Kimani, where human resourcing, particularly in the counties, is concerned?
Thank you so much, Olive. Kenya Medical Training College is the premier training institution in the country. We have 97 years of experience in training human resources for health. We have campuses in 45 of the 47 counties. We train over 99 courses in this institution. And just to mention from the whole continuum that our good doctors have talked about, right from community level, we have health promotion, we have community health assistants, we have public health officers, and we have nutritionists who can help in health promotion and being able to refer patients to higher facilities. For early detection, KMTC has several courses that can help in management of prostate cancer. We have medical laboratory sciences, we have medical imaging sciences. These are very key in PSA and also being able to do histopathology and being able to do imaging that is required for early detection and diagnosis. When the disease is confirmed, Kenya Medical Training College has several courses, a myriad of courses that are useful in managing the patient, right from nursing care, clinical officers at various levels of our facilities. We also have higher diploma courses that are very useful in management of the condition. For example, we have oncology nursing, we have oncology clinical officers. At palliative care level, we have palliative care nursing that we train at higher diploma level. When the patient is discharged and is at home, we require home-based care. And at home-based care, we have several professionals that we train at our facility here and various campuses in the Republic that can support in management at home. For example, we have nutritionists to support in terms of advice on nutrition. We have enrolled community nurses. We have healthcare assistants that can help at this level. Our oncologists have mentioned that at a certain point in time, there are the spread of the disease in bones and therefore could lead into cases where we need rehabilitative care. We have physiotherapy in this institution, and we have also occupational therapy that are very key in managing cases where we need rehabilitation. In summary, Olive, the institution currently trains over 66,807 students currently, and we have trained, our alumni are about 85% of human resources for health in the country. Okay. And therefore, we want to assure the country that we have capacity to produce sufficient human resources to support the UHC, to support prostate cancer management in the country, and also to support in health insurance perspective of management and financing.
Right.
Thank you.
I think what the point you're making, Dr. Kimani, is that specialized training. But let's take a couple of questions. First, from the audience, there's a young lady who had a microphone. If you can just raise your hand, you can, so go ahead, introduce yourself, ask your question.
I'm Rosemary Ramboi Kamau from the Department of Health Promotion and Community Health. So my question is...
You can project a little bit, Rosemary, so that they can hear you better.
My question is, apart from the peer-to-peer approach, which other methods are being used to encourage men to drop their attitude in order for them to turn up for the screening and the treatment for prostate cancer?
Okay. So how do we encourage more men to turn up? for the screening. I think you'll take that one. Phoebe, somebody else had a microphone. Go ahead, young one.
My name is Odero Kut, student at the University of Nairobi. My question goes to Mr. Ochieng. The SHA is going to cover prostate cancer screening, yes? But now, as by my perusal through the document, I saw that it only covers patients over 55 years, 55 and older. And Kenya is a high-risk country. The black population, as Dr. Kimani has mentioned, that screening should start from 40 years. So what provisions do you have in SHA to enable that to happen? Yeah.
All right. We can just pass the mic now. So we have some two gentlemen sitting next to each other here. Just pass it behind you.
Hi, good evening. My name is Alvin Mwawasi. I'm a final year medical student and also the chair of an initiative called Warrior Glow that basically helps cancer patients to cope with the side effects of cancer treatments such as chemotherapy and surgery. So through talking to a lot of the male patients, we've come to see that one of the challenges is the loss of livelihood. So a lot of them are weak maybe from the chemo or have incontinence issues after surgery. So my question to you would be, what can we do as not only healthcare providers, but also if you're a family member or as a society, to ease the burden, not just financially, but also mentally?
All right, so we'll take two more questions. You can just pass it on to the gentleman to your side and then to the lady behind you.
Yes, so good evening. So my name is Njoroge Maina. I'm currently at the University of Nairobi. I'm pursuing medicine and surgery. I'm in 4th year. And my question is mainly on the education sector, in line with training oncologists. I understand we have a very small number of oncologists in the country currently. And my question would be, all other factors kept constant. If we're able to take care of all these other factors to do with screening and so on and so forth, patients will definitely need specialized treatment from these oncologists. So my question goes to Dr. Primus. As medical students, maybe what would encourage us to go into this line of training as far as oncology is concerned, and even beyond oncology, talking about specialties like surgical oncology and so on. I've not had so many medical students saying that they want to actually specialize as oncologists. And you started by saying that cancer is actually an emotive subject. And so sometimes we are discouraged by the fact that, in taking care of patients, the prognosis sometimes may not be very good. So in line with the life I'd want to live when I specialize in oncology, maybe, when the prognosis is not very good, maybe I'd have to find myself losing some patients and so on and so forth. But, what should encourage us basically to actually go into this training in oncology?
All right, just pass the mic behind you.
Hi, my name is Candy Gitobu. I'm a 5th year medical student. So I have a question to Mr. Joseph. So on these, the new guidelines that you're planning for next year, July, and you claim that you're looking into worldwide and national guidelines for screening. Haven't these guidelines always been inexistent? So what new guidelines are these that you guys, that SHA organization is going through and getting advice from? And if the SHA is perfect on paper, but different qua ground, then doesn't that simply mean it's not perfect? Because that 75-year-old man in the village who has prostate cancer will not wait until next year, July. So is SHA, SHIF, or now Taifa Care?
Yeah.
So is it just built on a bed of dead and dying souls? So could you please clarify everything to do with that in regards to cancer? Thank you.
You said Zenny?
Candy.
Kenny.
Candy.
Kenny.
Yes.
Okay. All right, Joseph, you've gotten that question from Kenny. So do we start with those ones? Yeah. All right, so Phoebe, you can begin. There's a question that was asked by Rosemary. How do we get more men to get screened?
Thank you very much, Rosemary. Handling men requires innovation and innovative ideas. And just to take us back a little on statistics, the uptake of prostate cancer screening in Kenya among the men is very, very low, extremely low. And this is in comparison with other cancers, that is the female cancers. For example, the uptake of cervical cancer screening is about 24% from studies that have been done. But for prostate cancer, the uptake is 4.4%, just slightly about 4%. And it's even lower in the rural areas. So then it takes us back to the question, where are the men? In the urban setups, the men are professionals. They're in the workplaces. Then how do we work with the human resource department, existing services within the employer mechanism to reach out to the men? Maybe during tea breaks or during staff meetings, we can target the men who are above 40 or even those who are approaching with the much needed information. Where are the men? The men watch football. How about having the IC, the information materials in those clubs when they are watching the football, and you flip that information, or even an ad that is walking around? Where are the men? They're in the barber shops. Excuse my Joseph today is observing Movember. Movember is a no bead, no shave November to stand in solidarity with prostate cancer. But the men are in barber shops. How about having those materials in those places? Where are the men in the rural areas? They religiously attend what we call the chief barazas. In fact, I remember my dad and my grandparents will not miss a chief baraza. How about having a workshop during one of those barazas when they come and now telling them about the screening and demystifying, because as the Daktari said, we have moved from the era of the digital rectal examination, and now we have even better quantitative serum, PSA, that is even better and less invasive. Where are the men? They are in churches. How about we put in the religious leaders and have them on board, the mosques, the other religions, so that we have them on board? Men are in funerals, just interrupting the program, the community health promoter asking for the microphone and talking about those simple urinary early symptoms of urine issues that the men have, and talking about the high risk. And now, with the new guidelines of Ministry of Health, they're saying that one of the risk factors is not only a man who has had prostate cancer in the family, or even it is a man even with other cancers in the close-knit family. Above 40 years of African origin is at risk. So the question is, where are the men? They are in this room, they are approaching 40. How about you take those advantage and talk to them about the benefits of early screening? Because with cancer, early prevention, early diagnosis, early screening, early intervention will save lives.
All right. So, Joseph, I'll leave Odero's and Kenny's questions for you to answer. But let's go to the question that was raised, the questions that were raised by Njoroge and Alvin. And I'll start with you, Dr. Ochieng. How, he talked about how the prognosis in many of these cases, when they're detected late, is not good. How do you encourage more medical students to get into this field?
So thanks so much for this question. So we know from statistics that from 2030 and beyond, cancer is going to be the most common disease or illness in this country. And also in the same way, when a disease is most common, it will also be the most common cause of death. And therefore, we need more oncologists, we need more investment in institutions that train oncologists, we need more investments in treatment. Oncology or cancer treatment is one of the diseases which requires so many health. Actually, it touches all the health professionals. Like KMTC are training occupational health, physiotherapists. They are very key in cancer treatment. Palliative care form a very huge component of cancer treatment. The doctors can't do everything. We can't write chemotherapy, we can't write radiotherapy, we can't write other treatment and still cancel the patient. So we need another group of doctors to work with, called the palliative care doctors. A case like cancer prostate, Dr. Kimani has to do the diagnosis, has to do the screening, then when the people he gets with the cancer, he hands over to us. Now the government actually has spearheaded the cancer specialist training at the University of Nairobi, where I'm in charge of. We're currently having 30 oncologists ongoing training, 8 graduated last year. The government has also come up with a very attractive way to attract doctors to specialize in oncology. Like half of our students get scholarship, We even have attractive scholarship where students get 300,000 as a salary, and their tuition fee is paid for by us in a scholarship. The other thing is that the government has also made it easier for doctors who are in the county hospital to come and specialize in oncology. The oncology training is where when we do the interview for the whole country, we look at doctors who are coming from more remote areas. Like we have doctors coming from Marsabit, we have doctors coming from Maralal, even the extreme part of the country, Kajiado and all that, which is not normally done in cases of specialization in other specialty. And even more to that, the doctors who we give this scholarship are the doctors who come from the more remote parts of the country. And this is an attempt so that by the 2030, we could be able to actually catch up and have adequate doctors who have been trained and are coming from all these parts of various parts of the country. Now, oncology has changed. We are able to cure more patients today. 20 years ago, if you are stage 4 cancer, we'll give you little treatment. Today, if you are a stage 4 cancer, we give you more treatment. Immunotherapy is a drug which currently is not chemotherapy, it's a drug used for mostly stage 4 cancers. It costs up to 1 million in a month, and it is used for those in stage 4. We are moving away today from the word stage 4 cancer and dividing stage 4 cancer, those who are very sick we may do nothing about, to those who are, we can do something about them. And we are calling them patients we are treating with the hope of cure. Okay. And we are now able to cure more people than we were able to do before. Radiotherapy has changed, chemotherapy has changed, immunotherapy has changed. We have more modes of treatment, more cure. So doctors should not look at a cancer patient as a dying patient, but they should look at a cancer patient as a patient that can make a difference. We have patients with stage 4 cancer who have lived for 18 years, for 20 years. But again, we go back to the SHA thing. If you're in America today with a stage 4 cancer, you're more likely to live more than 5 years. If you have a stage 4 cancer in, say, Asia, where they have invested heavily on health, you're more likely to live about 2-3 years. If you have a stage 4 cancer in Sub-Sahara, you're more likely to live 6 months. The doctors are the same, the machines are the same, but what has been found is that the more investment we put in cancer treatment, we are able to make them live a little longer. They'll be able to afford the 1 million treatment, which can make a huge difference for that group of patients who can benefit. Okay. So doctors should be encouraged, they have to know about cancer. And again, even in the periphery, most of the patients that doctors see today in their clinics are other patients we have treated and sent there, or patients with cancer.
Okay.
Yes.
Dr. Kimani, the question I was asked by Njoroge about this being an emotive, cancer, but he talked about the incontinence, the consequences, the effects of having prostate cancer. What's your response to him?
The answer is we need to pick those cancers in the early stages. That's the key. That's the message we are trying to drive. And I hear what Dr. Ochieng is saying and appreciate the government for the things that they have gotten right. There are places that have equipment and everything else. The problem is we are fighting this animal in a very disjointed manner. Because the doctor you train from Marsabit, when he goes to Marsabit, what does he find? A dispensary. What is he going to do? You have all the knowledge in this world, you have all the skills in this world, but you have nothing to work with. And yet there is another facility that has the equipment, but doesn't have the personnel to do that. I shudder when I think, Barrows, supposing men were so keen and they listened to us, and they all came for screening, so what next? They have all appeared, they're ready for screening. Are we ready to take them? When we pick these cancers in the early stages, how many of us are able to do radical prostatectomies in this country? How many of us are able to do radical radiotherapies, and how many can access the radical radiotherapies, because that's a treatment for early prostate cancer? Are we able to absorb that? And therein lies our dilemma. How do we marry these resources that we have, meager as they may, so that we may use them in an appropriate manner, such that if you have an MRI, you can't have an MRI and not have a radiologist. You can't have an oncologist and not have a radiotherapy machine. You can't have a surgeon who has no theater. But that's sadly where we are. And that is why we are asking the Council of Governors, because they took up this animal called health. How do they, when they sit in their meetings, we are imploring upon them, how do we organize our resources such that at the end of the day, we get the best that we can? The young man is interested in oncology, but when he goes back to his governor, the governor tells me, we already have an oncologist, his dream is over. And yet there is somewhere else, that governor may not need an oncologist, but there's another governor who wants an oncologist. Another governor needs a surgeon. How do we bring them together such that at the end of the day, we have the common good of our country? And the resources that we are talking about are not as major as one may think. 2 billion shillings we hear. Today you are reading news, and you are telling us about 2 billion lost. Imagine 2 billion lost to an individual. How much can you do with 2 billion if I'm given that money to run oncology services in Kenya? It's massive. So good governance is equal to good healthcare. Okay. And we are hoping, we can only hope that things are going to turn around with the new administration. As far as the share is concerned and the rebates therein, I think reading on the face value, we have a lot of potential benefits. Again, it needs only the stakeholders to be brought in so that we can tweak it and make it a little bit better than the way it is. And I believe that if you listen and the healthcare workers come in, we are going to get far with that share if you are willing to listen to the public. All right. And the doctors.
And on that note, Joseph, the questions that were raised by Odero, that were raised by Kenny, and Kenny didn't mince her words. She said, what's the point of something being perfect, quote unquote, on paper, and in reality is not delivering?
Okay, I'll start by just appreciating where we have come from. Before 2017, then NHIF used to have a budget of around 13 billion. And that was covering mainly rebate for patients when they get admitted. Fast forward, before now SHA came in, we were dealing with a budget of around 80 billion, with now having cancer being managed through sessions, bringing in the radiotherapy and the surgical interventions. The current estimated budget for healthcare in the country is around 700 billion. So if you are to fully eliminate out-of-pocket payment, then the government needs to work with around 700 billion. And we are in a resource-strained environment. So we have to appreciate that at the same time, the government would like to cover everything, but there are priorities that you have to look into. There's what we call health technology assessment, whereby you have to look into what is more catastrophic. For example, when you're looking into healthcare, you ask yourself, if you have 2 billion, for example, and you have one client who will have a heart attack, which will cost maybe 1.5 million to treat. There's another one who needs a kidney or is undergoing dialysis at around 21,000 every week. And then you have another patient who requires another service. So the government has to look at what it has. And the current budget the government is working with is around 267 billion. That's around 99 billion for SHIF, where people are contributing, around 61 billion for primary health care, and then around 107 billion for emergency, chronic, and critical illness. That is what we were projecting to have. And then we also understand the budget happened, because from that, 107 was to be, the ECCIF was to be funded by government, and then the 61 billion was also to be funded by government. If you had that money, then we would have been able to cover all these, including ICU and the rest of the services. So we had to prioritize, and that is why we are saying the sooner the budget is available, if it's available by January, the costing and all the details are ready. So it is just about, once the money is available, we roll it out. So we have moved, and every healthcare benefit package will always be progressive. It will never be static, and that's why I started by just giving out the journey to show that we are moving. However much we still have challenges, but we are moving towards having better every day. We are not going back behind, and we appreciate what Kenyans need, and the government is really working towards that. Even where UHC has really worked like Thailand, they still have challenges. But the most important thing is being positive and ensuring that every day you don't go back, but you move forward.
So basically you're saying people who need the PSA, for example, or qualify, age-wise, risk factor-wise, will have to pay out of pocket?
For now, we have started with that age group of 55 and above, once it's rolled out. Of course, I've mentioned the costing has already been done, and we're also monitoring utilization trends, because the most...
Because Odero was asking, he was saying, why is it 55 and not 50?
And that's what I'm saying. We are looking into what we can cover now, because the aspect of sustainability is also very key. There's no need of rolling out a benefit package that in the long run you won't be able to pay hospitals. So we're working with the budget that we have. We start with the 55, and then as more funds come in, and as more funds is allocated by Parliament, then we add that whatever is available. About her question, she was asking about the guidelines. And the guidelines we are talking about is the guidelines for management. And these are guidelines that have been provided by the National Cancer Control Program under the Ministry of Health and the National Cancer Institute. And it was done, the guidelines were developed through a consultative forum and stakeholder engagement. So oncologists were involved, radiologists in putting up these guidelines, so that the what is going to be used in terms of enabling us to have a standardized management of patients for various cancers.
Okay.
Yeah.
So let's take another round of questions. There's a lady with the glasses. You had a microphone. We'll start with you. Very, remember, succinct. Also, I'll ask my panelists to try and be as direct as possible.
Okay. Good evening. My name is Paris Waitiki, and I'm from the occupational...
Sorry, I didn't catch your name?
Paris Waitiki.
Paris?
From the Occupational Therapy Department. And mine is more of a consideration. My question to the panel is, has anyone ever considered that rehabilitation could be like the one thing that scores treatment in this country? Because when we have rehab, then we can have people getting screened. My takeaway is from HIV and AIDS. Currently, when anyone hears about screening, about HIV and AIDS, no one is scared, because they know that the quality of life that comes even with a positive diagnosis does not really matter, because the quality of life will be maintained. But with cancer, everyone is scared of what happens if I get the cancer. It is a sickness of the body, but it is also a sickness of the mind, and a sickness that will affect the family. So has anyone ever considered that knowing the diagnosis is also something that keeps the patient away from wanting to know? And has anyone ever considered that if the government really worked on rehabilitation aspect, it would just really change the attitude of everyone involved in getting the screening aspect?
Okay.
So my question is to Mr. Joseph, how much do you guys really put in the work, and how much do you allocate to the rehabilitation department?
All right. Hands for questions, young man.
Edwin Mugambi.
Edwin?
My name is Edwin Mugambi from the Faculty of Public Health Sciences from Community Oral Health Department. Thanks so much, panelists, for the information that you're giving us tonight. It is quite involving. My question is a bit precise, and this is my question. Now that we have accepted and we have appreciated that we have a problem in prostate cancer, are there any patient support groups for patients with this condition? And if they are there, then can you give us a few of them that we may be able to know them? And if still they are there, then how impactful are they in the society? Thank you.
Okay, so you'll take that one, Phoebe. All right, I'll take 3 other questions. I really haven't taken many from this side of the room. Is there a microphone near there somewhere? We can take, okay, pass it on to the gentleman with the glasses. I see you in the back as well.
My name is Daniel Ndumia Mwangi, a physiotherapist by profession, but still under training. So my question is, in terms of physiotherapy in collaboration with the other medical practitioners, in terms of physiotherapy and cancer recovery, what are the most effective rehabilitation approaches for patients undergoing chemotherapy, to be specific?
Okay, just pass the mic behind you. There's a gentleman with the glasses.
Hi, my name is Forrester from the Department of Pharmacy. My question is...
you said Forrester?
Forrester, yeah, from the Department of Pharmacy. How do you manage some of the side effects that come with chemotherapy? How do you empathize with the patient when he comes up with issues such as infertility, gynecomastia, and erectile dysfunction?
All right, so pass, there's another gentleman behind there in the back with glasses as well, and then I think we'll take a lady. Do you have a microphone? Okay, just pass it on to her. Just behind you. In the black? Yeah. All right, we'll start with, have you got in the mic? Go ahead.
Good evening, everyone. My name is Pius Omolo, nursing student and also the president of Student Representative Council. Indeed, prostate cancer is a very emotive topic. At a personal level, 2 years ago, we lost our uncle. So before my uncle started to be unwell, he started manifesting with difficulty urinating, hematuria, and sweats during the night. So he decided to go to hospital, and then several tests were done, and then the bad news came that he's diagnosed with prostate cancer. And then there was a recommendation from the medical team that he undergoes surgery. Then 6 months after surgery, it was terrible on him. He started experiencing serious symptoms. And then when I could go home during that time, he used to tell me, Pius, this surgery has killed me. Before surgery, I was just doing well, but this surgery is what is killing me. So I want to ask Daktari that how effective is surgery in management of cancer?
Okay, so that's for Dr. Kimani. All right, the young lady can...
Hi, my name is Grace Omoto. So I have a comment and a question. My comment is in response to what someone asked about support groups. So my team and I are actually here. We run a student-led initiative called Warrior Glow, and we are all about providing, helping people who are undergoing treatment for cancer to be able to cope with the side effects. So that's one of the support groups that are present, and we are just here in UN. My question is about digital health. So digital health is emerging transformative force that is happening in Kenya right now, and it is revolutionizing how healthcare is accessed and delivered. And with these technology and mobile health solutions, we are standing at a pinnacle of the medical era right now. So how do you think digital health could affect cancer treatment and cancer screening? Do you think it is beneficial or not?
All right.
And it is directed to anyone.
Okay, I didn't catch your name, sorry?
Grace Omoto.
Grace, okay. So I think Dr. Ching, you'll take that question from Grace. Let's take those questions. There's a question that was asked by Paris, and she talked about, HIV and AIDS, people no longer view it as a death sentence. How do we get to that point with cancer? Dr. Kimani?
Thank you. And the main issue is, like, again, we are saying, and our emphasis tonight is we treat these patients early because early prostate cancer is completely curable. I think that's the message that we want to pass on. And number two, even those who present with late disease, there is hope. The only difference comes in what are your treatment objectives as a doctor. When you come with early prostate cancer, our aims are to cure you of the disease. When you come with late disease, our treatment objectives as a doctor is to palliate. Palliate means we give you the best quality of life possible. But we can only do so with the resources that we have And number two, we can only do so depending on the symptoms that you present with or the type of, the level of disease that you've come with. For example, if you come with a spinal cord compression, and therefore initially you are walking, now you're not able to, I have only a window period of 2 weeks, within which when I get you, we can make a diagnosis, initiate treatment, and perhaps offer you a chance at recovering your mobility. If that doesn't happen within the 2 weeks because of bureaucracy, money issues, distance, lack of access, and everything else, you end up now presenting to us 1 month later. I may have the knowledge and the know-how to handle you, but it is too late. And that's why you're trying to tell the public that we need to identify these things earlier. As far as rehabilitation is concerned, rehabilitation, like I said, cancer of the prostate care is a multidisciplinary approach. It involves everybody, including the people in rehabilitation. Do you know there's something called penile rehabilitation, for example? These men who have prostate cancer, often we give them either surgery or we give them radiotherapy, and we interfere with their erectile function. But we have modalities of helping them recover part of that sexual function. And that is where issues of penile rehabilitation comes in. That patient who came with a cord compression will require rehabilitation services. Even after you give the radiotherapy, you give your hormonal therapy, the patient, you have to go through occupational and physiotherapy for them to regain a little bit of their function. And therefore, there is room for everyone, including the nutritionist. If I show you barrels of the patients who are diagnosed with prostate cancer, there is a significant proportion, up almost 50-50. 50% die of cardiac-related diseases. You have prostate cancer, but the cause of death is cardiac, not necessarily the prostate cancer in itself. So even by coming
How
to
does that happen?
Yes, thank you. When patients come into, patients who have cancer of the prostate, our mean age of diagnosis is 68 years. What is common about our 68-year-olds? Most of them are diabetic. Most of them are hypertensive, they have lifestyle diseases, they have kidney diseases, and the like. All those are risk factors for cardiac disease. And therefore, we may spend our time addressing the cancer and forget that bit of their other risks. The treatments that we give, some of them will give you hypertension. Some of them predispose you to forming clots within your body, or predisposing you to cardiac and coronary events. And therefore, it behooves us to remember that part, such that when you get these patients and you put them on the proper nutritional diet, put them on exercise and everything, you are helping reduce their risk of death, even if you're not treating their cancer. Mm-hmm. And that is why the multidisciplinary approach is very helpful for our patients.
All right. Phoebe, the question on support groups, how critical are they?
Thank you very much for that question. We have discussed here that cancer diagnosis is a very emotive process. And we cannot underscore the importance of support groups, because what we have seen work from our member organizations, those that run support group, is that the support group modality for a prostate cancer patient will be different from a support group modality for a breast cancer patient. They have different needs, different ways of managing side effects. So yes, we do have that. And I'll just give an example of one of our member organizations called Faraja Cancer Support Trust. They have support groups for men. And also they try to go out and do for caregivers. So remember, at the end of the day, this man will go back to a family. They will need for this wife to understand there will be erectile dysfunction with the treatment like surgery, side effects. There will be need for them to understand that nutrition has to be observed. And also there is also another organization called A Fresh Chapter. They also do psychosocial, because it is very important for mental health on psychosocial. However, we are noting that the support groups, the male-led support groups are not as many as the female-led support groups, especially for the female type of cancers. So we are calling on the referral hospitals where the patients come in. Once they come in and they're stable, even before they're stable, link them up to a support group. And support group is as easy as organizing a meeting and calling maybe someone to come and talk to them, from physiotherapy, from nutritionist, or even the doctor who come to do the navigations and also to help them through treatment. So they are there. They are still very, very minimal and few. And we really need the support of the oncologists, nurses, organize the registration people to help us get these patients and put them together, because when they're together, they're able to share experiences, and even in that, they're able to build themselves to one day be what we are calling out to be the community health promoters who are cancer patients with lived experience.
All right, Dr. Ochieng, the question of we're living in the digital era. How do we incorporate that, even our mobile phones, when it comes to screening, cancer screening?
Thanks so much. So technology has changed many things, including cancer treatment, where we have seen how technology has made it much better, much easier. Many years ago, we treated cancer prostate for 40 days. That's about 2 months. Today, we can treat it for actually 1 month, 28 days. And even some cases, we can treat for 5 days. And thanks to technology. Technology has also helped us actually reduce the side effect. One of the reasons why even people tell me they don't want to go for screening is because what they have seen happened to their father, happened to their sister when they went through cancer treatment. This is one of the most complicated treatments in the world, that when you go for cancer treatment, along the way, you become sicker. The aim of treatment is usually to make you better. But somehow cancer treatment tends to have a little more side effect. And that is why many people think that if I'm found with cancer, my dad was treated with cancer prostate. He suffered so much, but he didn't suffer because of the disease. He suffered because of the side effect. And now we are using digital. In this digital area, we are utilizing some of these technologies to even reduce the side effect, leave alone even the screening. Of course, screening it will help us in data collection. Screening it will make us be able to do it much faster. But area where we think digital technology should be focused quite a lot is the cancer treatment. Many patients actually are living cancer treatment and opting out for alternative treatment. And it's purely because of side effects. Many patients, as Dr. Kimani said, most cancer prostate are old people. They have diabetes, they have hypertension. The drug that we use quite a lot to jab people in the tummy, the hormone treatment, it also affects the heart. It looks a very harmless drug. You don't have nausea, you don't vomit, it doesn't affect your appetite. But it makes you drain water all over your body. It makes you get weaker down there. It can affect your heart. It makes you pile up a lot of fat around you. It makes you very weak in the limbs. It makes you get extreme fatigue. But the drug itself looks not that bad, because what we fear most is the vomiting, the loss of air with cancer treatment. So the world actually is utilizing these technologies now to make cancer treatment. How can we reduce the side effect? How can we make it up? Another area where we believe digital technology is going to help us is in research. The only way we are going to change, the only way we are going to know whether we need to do it better, the way we are going to know whether the black people actually react to these drugs, because most of them were done tests in the West, is through technology. And this technology can be harnessed and made much easier with digital era, where we can be able to take black people, do the same research, and in a very faster way, get the same research in the white people, and be able to get a result, and it forms the way we can change treatment. But the area we have to focus on is treatment. Screening, of course, that go a long way, and other things.
All right. There was a question on surgery that was raised by the young man about his uncle, who said he was worse off after surgery.
Thank you. I wanted to compliment his statement as far as technology is concerned, and give examples of why you're using technology. This doctor, who is a radiologist idling in Marsabit, and the MRI is being done in Kericho, he can be able to report that MRI from Marsabit, because all he needs is a barcode. Those images are uploaded, and he can go through them and assist in reporting. That's one area that can really help. Every Friday morning at 7 a.m., urologists across the country, oncologists have a meeting at 7 a.m. every Friday, where we discuss difficult urology cases. We do it online on the Zoom platform. using money and internet from our own, which SHA is not going to reimburse, and which I have to deduct from my meager payslip, but it is for the benefit of our country. And that's one area that can really, AI, where technology is coming in. Reporting of slides, pathology slides, can be done through AI nowadays, right? And importantly, when it comes to, you can now operate a patient in Kenya or in Germany. You have robots, and robots are controlled by the internet.
That's possible.
Yes. Do we have a robot in Nairobi? The answer is no. How much does it cost? Only 200 million, compared to how many billions we lose every day. So if we are only a little bit careful with what we do with our resources, barrows, I'm telling you, in Nairobi today, and I must commend the government where it has done well, because we are trained. People are being trained. The only area that is missing in prostate cancer care, I think, is only theranostics, where you use materials for very advanced prostate cancer. And we were in a conference in Kisumu the other day, and somebody in 2 weeks' time is saying he's going to set up theranostics in the country, which is a very big plus. But now, how do we if you're saying we are doing well, but we can do better? That's the message I think I want any government official to know. We can do better. We just need to coordinate our efforts, and we will move forward.
All right. So I want to invite you to make your final remarks as we take some questions from our online audience. So just about 2 minutes less each. There's somebody here who asked, there is a myth that regular sex prevents prostate cancer. Is it true or a myth?
It is a myth. And I think it's propagated by men who want more sex. but to put it into perspective, Barrows, the risk factors for prostate cancer, I want us to be on the same page. The major risk factors for prostate cancer are 3. Increasing age, your family history, and finally your ancestry, if you are black. And if you look at the 3 of them, they have one commonality. There's nothing you can do about it. You can't stop the clock. You can't change your family. Neither can you change your ancestry. But what can you do? That's why we are saying, if you can't do anything, at least detect it when it's early, because you can treat it. The rest, in terms of obesity without looking at the speaker, is you can help reduce the side effects that come with the treatment. You can reduce the complications that come with the treatment through dietary adjustment, through exercise, through eating a healthy diet and avoiding too much nyama choma. That bit we can do, but it's a very small bit. The bigger bit, there's nothing we can do about it. And the only thing we can do is detect the disease early.
All right. So looking at some of the, that's I'm assuming is your last remark.
If I may, so then the next bit is where we come in as healthcare, because I want to address myself to the healthcare workers, because most of these patients who come to us have visited a health practitioner at any one time. That's a sad reality. And the delays that we sometimes attribute to patients coming in late are delays caused by healthcare workers who are unsure of what they want to do. And that is why I'm part of the team that formed the guidelines for prostate cancer screening and treatment. And in the guidelines, we put in the role of the healthcare worker from the community health provider, sensitizing people. Let's go for screening. Now the health center is able to do the screening, that blood test, because Dr. Oluochi has trained a lot of graduates. Now the question is, he's training 68,000 graduates. Where are they going? Once he has trained them, there is work out there, but there are no workers where they are supposed to be. So we need to plan and improve on our human resource management. Whatever we do, even if we jump up and come down, at the end of the day, if we do not improve on our health resource management, human resource management, all our work will be nil.
All right.
Thank you.
Dr. Ochieng, as I invite you to make your final remarks, Joseph, prepare yourself for this question. Benson Ambuko says, my dad is Dr. Ochieng's patient. Today I was initiating SHA approval for his vital enzalutamide drugs at Nephromed Center Upper Hill. Now, up to now, the approval hasn't been done. There's a question here from Rosa Temo who says, a question for Otieno, please clarify, 1, the limit for oncology services under SHA-SHIF, 2, whether any copay applies for the patient to settle out of pocket, 3, if there is copayment, how much is it? Did you catch that? All right, Dr. Ocheng, you can go ahead and make your final remarks.
Thanks so much. So one of the big problems, I train cancer patients, I train cancer doctors, and I see cancer patients. The world has invested quite a lot, but the outcome of cancer treatment in Africa is still inferior to cancer treatment in the developed world. And I think we need to go back to basics to understand the cancer we are treating, understand our people. Everybody, we see cancer stage 4 in professors and wonder, where were they all this time? Why did they refuse to go for PSA testing when they know? We see cancer stage 4 even in doctors. And those are the challenges we see. So to me, is that the Western world seems to have a cancer which is a little different. Like you see, Dr. Kimele said we're having more black people with the cancer. Phoebe has said we have less people going for screening. But they know it, not that they don't know it. The kits are very cheap, but why are people not going? So to me, we need to understand our people, we need to understand our cancer, and we need to invest more in research so that we can make better outcome. Some of the treatments are not working, and we think they're working. The only way we will get the answer to that is when we take that biopsy and check it and see what works best. So investment in research, investment in these young doctors and nurses so that they can be able to revolutionize the way we do things. Okay. But I think the problem has been we take too much from the West and bring it to Africa. But we're dealing with one disease which behaves differently in 2 different places.
Okay. Thank you. Phoebe, your final remarks as succinctly as possible.
Thank you for giving us this opportunity to talk about this. Talking on advocacy, from what we are hearing, the cases of cancer are increasing day by day. And from what we are hearing from SHA, SHIF, UHC, it seems like the future is not so as bright as we expected. So then, my take home is that how do we work with the partners, the manufacturers, the government, the pharmaceuticals to reduce the cost of cancer treatment, and looking at the cost throughout the entire continuum of care, from prevention to actual treatment and even rehabilitation. When that cost is reduced, because there's a bit of bias with the male cancers. In the female cancers, we have had access programs that have worked for breast cancer, and now some patients can access, with advanced breast cancer, can access very affordable treatment, even with cervical cancer. So my take home is that calling upon pharmacists and the government to work on those access programs. And I would like to tell also SHA that please kindly, the 300,000 oncology package is not enough. For now, it seems like it's enough because patients are accessing care, but in the next 6 months, it will be depleted, and then they will be told to go back to the pocket. So please, as you work out the system, consider the oncology package, and then also work with us, because we would like to push for evidence-based data, because how we would like to know what informed that kind of limited package, and yet we have data on treatment costing, data on research and all that. So let us work around research-based information on costing for cancer care, and men come out for screening. It is very easy and it is accessible in the different setups that we have, because early diagnosis will save lives.
What was it under NHIF, the package?
The package, Joseph, you can tell us?
Up to 100 for first line and then 600 for second and third line.
So they have almost halved it into half. It is almost into half. So please, it is not enough. And just tell us, we would like to know what informed such a limited package. Treating cancer is extremely expensive, and that's why we are calling for the access program. If NHIF and if SHA does not work for us, then where does the patient go? And yet we are saying that the treatment should be captured early. But when we waste more time, then it advances and it becomes more complicated and more expensive to manage.
Joseph, your response?
Okay, so for cancer, what we have done is, I mentioned we are using guidelines that have been standardized. So if you look at the costs within those guidelines, then it takes care of around, the figure is around 400,000. That is for diagnostics and then for management. The guidelines, we're looking at around 80% of patients being covered within that 400. So that covers majority. We know we'll do better. And then for those who exhaust the 400, then we're looking at the next budget for emergency and critical illness fund. So once that is available, then be able to join that. The question on pre-auth, I think the system has been doing, the pre-authorization turnaround time has been well. So unless maybe we get that specific case, and then we can follow up and see what is really happening with that case. Because I know the turnaround time has been really reduced.
All right, but you have your stakeholders here, they're telling you, as it is set up, it's just not working.
It's not working, and I know the critical illness fund that he's talking about, they said it is subject to availability of funds. So it is there on paper, but subject to availability of funds, and we are not seeing that availability of funds. So is it too much to ask for that package to be expanded a bit? 300,000 is not enough to take care of cancer treatment, right from surgery, chemotherapy, radiotherapy, or the combination. It's even worse now when a patient needs to travel overseas. You can only imagine. Yeah,
okay.
So, yeah.
All right.
I urge him that whatever is working doesn't need to be sold. We will see it working.
That's a good point as any. To conclude this conversation, I want to thank our host, the Kenya Medical Training College, for hosting this conversation on prostate cancer. I want to thank my panelists, Dr. Primus Achieng, a clinical oncologist, University of Nairobi, Kenyatta National Hospital, Phoebe Ongari, Executive Director, Kenya Network of Cancer Organizations. Sitting right next to me, Dr. David Kimani, Senior Medical Specialist, Urologist, Kenyatta National Hospital, and Honorary Lecturer, Department of Surgery, University of Nairobi. Not forgetting Joseph, I appreciate you in a tight spot. Joseph Otieno, Head of Benefits Design and Actuarial Services, SHA, but it is all in the spirit of creating awareness and adjusting as needed. Thank you very much to you for watching. Thank you so much to our audience for taking part in the conversation. Enjoy the rest of your evening.